The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi everyone, welcome to the second part of your OBGYN lecture. And for this second part, we would be focusing more on the pathologic side of pregnancy. We'll be discussing preterm labor, PPROM, the fetal complications, as well as maternal complications during pregnancy. Hindi natin i-cover lahat ng medical complications in pregnancy, but there will be select topics that are high yield and have been asked in the boards. Yung mga hindi natin madidiscuss, we'll try to discuss that during your Pearls lecture. So let's begin. Starting with preterm labor. So, as we all know, preterm labor is defined as labor before 37 weeks age of gestation. And it's actually divided into 3 more classifications. If it's less than 28 weeks, that's your extremely preterm babies. If it's 28 to 32 weeks, that's very preterm babies. And for 32 to less than 37 weeks, that's your late preterm. And pwede rin natin i-classify yung infants natin by their birth weights. And we defined low birth weight as any weight less than 2,500 grams. If it's less than 1,500, that's very low. And if it's less than 1,000, that's extremely low birth weight. And with preterm labor, the greatest risk factor of which is a previous preterm delivery. And the risk actually increases with the number of previous preterm deliveries as shown in this table. So if you have a delivery of a baby more than 35 weeks age gestation, your succeeding risk for a preterm delivery is only 5%. But if you have a delivery of a baby 34 weeks age gestation or less, it goes as high as 16%. And if you have 2 prior preterm deliveries of less than 34 weeks AOG, you have a risk of 41%. And we actually have a 50% mortality rate for births at 23 weeks age of gestation, while the mortality rate is slightly higher than full-term neonates for birth after 34 weeks AOG. Kasi remember, after 34 weeks AOG, by this time, dapat mas develop na yung lungs ng baby mo. And which is also the reason why, pagdating ng 34 weeks age of gestation and above, we usually do expectant management. So now, due to newer technology also, the peri-viable threshold is between 20 to 26 weeks AOG if you're gonna base it on Williams 26th edition. And by peri-viable, we mean that by a reasonable chance, although not a high likelihood of extrauterine survival at this age. So there's a chance of extrauterine survival, pero not highly likely. But still, there's a chance. And the age of viability actually varies per institution. Now, though, most institutions and guidelines would pertain to 22 to 24 weeks as the current age of viability. So this is a table derived from Williams and showing the general guidance for threatened peri-viable births. And even if, as you said earlier, the threshold right now is between 20 to 26 weeks AOG, there is still high mortality rate in fetuses delivered before 22 weeks age of gestation. So that is why in threatened peri-viable births less than 22 weeks and below, emergent cesarean deliveries are reserved only for maternal indications and resuscitation. Steroids, tocolysis, and other measures for the fetus is not recommended before 22 weeks age of gestation because they're not likely to survive. By 23 weeks, fetal support may be considered, and recently more institutions are also considering cesarean deliveries for fetal indications at this point. So pwede na. Before this, maternal indications lang ang pwede nating reason for cesarean deliveries, but for viable pregnancies, you may consider delivering for the sake of the fetus. So the management of preterm labor includes several things, one of which is hydration. So with dehydrated patients, they have been found to have increased vasopressin or antidiuretic hormone. And ang vasopressin natin or your ADH actually has one amino acid in its component that differs from oxytocin. So your vasopressin and your ADH would actually trigger the oxytocin receptors. So if you have increased vasopressin or ADH in the body due to dehydration, this would also cause contractions in your mother. So very important that your um, mothers who are in preterm labor are well hydrated. We also give corticosteroids for fetal lung maturation, and this is recommended between 24 to 36 weeks age of gestation. It has been found to be beneficial even in the late preterm period. Although hindi required pagdating ng 34 to 36 and 6 weeks, meron pa rin tayong mga consultants who would give corticosteroids at this point. And pwede rin naman kasi beneficial pa rin siya at this point. We can give corticosteroids in the form of betamethasone or dexamethasone. If it's betamethasone, we give it at a dose of 12 milligrams IM every 24 hours for 2 doses. While if it's dexamethasone, it's 6 milligrams every 12 hours for 4 doses. So, in studies actually show na in terms of efficacy, walang nakakalamang dun sa betamethasone or dexamethasone. However, yung advantage ng paggamit ng betamethasone is that you're able to complete the steroids earlier. Like after 24 hours, completed mo na yung steroids. And for patients who are actually at a higher risk for delivery, this is more beneficial than using your dexamethasone. Ang disadvantage though ng betamethasone is that it's very expensive compared to your dexamethasone. So, if you would notice in government institutions, karamihan ang available would be your dexamethasone. So for preterm labor also, we can give tocolytics, and the idea of which is at least to delay the delivery by 48 hours to allow treatment or administration of your corticosteroids for fetal lung maturation. We have several tocolytic drugs including your calcium channel blockers in the form of nifedipine. So ang nifedipine nyo or yung calcium channel blockers would decrease calcium influx into the smooth muscles including your uterine muscles. We can also use prostaglandin inhibitors in the form of indomethacin. As we all know, prostaglandins would increase your intracellular calcium levels. Kaya natin to ginagamit sa induction of labor, augmentation of labor. So inhibition of your prostaglandins would also inhibit uterine contractions. However, for indomethacin, it has been found to be associated with premature constriction of your ductus arteriosus. So this is not a usual agent we use in tocolysis. Magnesium sulfate, besides using it for preeclampsia and for neuroprotection, may also be used for tocolysis, and the mechanism of which is through decreasing the uterine tone and contractions by acting as a calcium antagonist and membrane stabilizer. You can also use oxytocin antagonist in the form of atosiban, although this is not usually used here in the Philippines. So they're selective oxytocin vasopressin receptor antagonists. And we also have your beta mimetics. Under beta mimetics, we usually use terbutaline and isoxaprine. So under beta mimetics din yung isoxaprine. And the mechanism of which is through decreased free calcium ions due to increased CAMP levels in the blood. So, yung calcium mo nasa-sequester in the sarcoplasmic reticulum. So, magnesium sulfate is also used for preterm labor, hindi lang for tocolysis, but mostly for neuroprotection. For neuroprotection, it's recommended to be given between 24 to 33 weeks if the woman is at risk for delivery anytime soon. And the dose of which is administered at 4 to 6 grams IV loading dose, slow IV loading dose over 20 minutes, and a maintenance dose of 2 grams per hour for 24 hours. If papipiliin kayo between 4 and 6 grams na loading dose for your magnesium sulfate for neuroprotection, the answer would be 6 grams. So in Williams 26th edition, specifically 6 grams na bolus bolus dose na over 20 to 30 minutes ang binibigay for neuroprotection, followed by a maintenance dose of 2 grams per hour. And this has been asked in the previous PLEs before. So let's move on with PPROM, or your preterm premature rupture of membranes. So wag kayong malilito pag sinabi nating PROM, that's premature rupture of your membranes, or now we can actually call it as pre-labor rupture of membranes. Ang pre-labor rupture of membranes would pertain to rupture of membranes before the onset of labor in a term woman. So if meron kang pre-labor rupture of membrane, so nag-rupture siya bago ka magkaroon ng cervical dilatation, before the onset of regular uterine contractions prompting cervical change, that's your PROM. And if it happens before 37 weeks, that's your PPROM. So PPROM stands for preterm premature rupture of membranes, or preterm pre-labor rupture of membranes. Okay? So if meron kang patient na less than 37 weeks in labor, so naka-preterm labor siya, tapos nag-rupture yung membranes niya, it's just called your preterm rupture of membranes, and wala tong acronym. So yung acronym na PROM and PPROM is applied for pre-labor rupture of membranes. And then for prolonged rupture of membranes, we define it as ruptured membranes more than 18 hours before delivery. So for PPROM, it has been found that without intervention, around 50% of ruptured membranes would lead to labor within 24 hours, and less than 75% within the next 48 hours. So that's if hindi kayo magtotokolize, it has been found na magpa-progress talaga siya into labor after 24 hours in 50% of patients. And for patients na 34 weeks and above, as we said earlier, by this time, dapat mas develop na yung lungs ng baby. And pagdating ng 34 weeks and above, mas expectant management na tayo. Okay? But again, we may still use your corticosteroids up to 36 weeks for fetal benefits. Less than 34 weeks, we should initiate antibiotics, as antibiotics can lead to longer latency period before the onset of labor. And we give, our usual antibiotics would be in the form of your ampicillin with erythromycin. So the first 48 hours would be IV, followed by 5 days of oral na erythromycin and amoxicillin. So ang binibigay natin na antibiotics for PPROM would be a total of 7 days. The first 2 days would be IV, the next 2 days would be oral. If you may also give azithromycin or orally, once one dose lang ang binibigay natin, and 48 hours of IV ampicillin and 5 days of oral amoxicillin may also be recommended. So again, so that's ampicillin with azithromycin, and then 1 dose of azithromycin and 48 hours na IV ampicillin. So yung prematurity risk natin is almost equivalent to infection risk between 32 to 36 weeks. And up to this point, the risk for prematurity would drive the management for PPROM and preterm labor. After this point, the risk of infection would motivate the immediate delivery of your fetus. So ang common practice again would be to deliver at 34 weeks if PPROM na. So this is a summary table from Williams showing the management of pre-labor rupture of membranes. So pag term na tapos PROM, so induce, you should deliver, you should initiate GBS prophylaxis as indicated, and treat any intraamniotic infection if applicable. If it's 34 to 36 and 6, so that's your late preterm. Again, that's expectant management already. Deliver your baby. You may consider a single course of corticosteroids since may benefit pa rin naman. And for delivery, GBS prophylaxis pa rin that's indicated. And again, treat for intraamniotic infection if needed. If before late preterm, and if there's no maternal fetal indications favoring delivery, you may do expectant management. You should give a single course of corticosteroids, and you should also initiate antibiotics to prolong the latency of your pregnancy. Pero syempre, for very early preterm babies, and actually kahit naman yung mga 33 and 6, best to do perinatal counseling so that the treatment or the management of which will be patient-directed. So let's move on to fetal complications of pregnancy, and the first of which would be your disorders of fetal growth. So small for gestational age babies would be defined as your estimated fetal weight being less than 10th percentile for age of gestation, usually by Hadlock yan. So, factors leading to your small for gestational age fetuses could either be due to decreased growth potentials. And by decreased growth potentials, this would include your congenital anomalies, meron ka talagang small mother, so pwedeng constitutionally small talaga yung baby mo, or intrauterine infections. Other factors would be factors that lead to intrauterine growth restriction, including preeclampsia, placental abnormalities. And usually for factors that would lead to intrauterine growth restrictions, these would be your pathologic disorders that are associated with uteroplacental insufficiency. So, fetal growth can be divided into two phases. Before 20 weeks, primarily hyperplastic ang growth ng fetus mo. And by hyperplastic meaning, we still have increase in your cell number. And if your insult is as early as this point of your fetal growth, the growth restriction is still symmetric. So, ibig sabihin, yung head mo, yung chan mo, yung body parts mo, all symmetrically small. As compared to if the insult is after 20 weeks, by this time, primarily hypertrophic na yung growth natin. So, by this time, dapat mas completed na or marami na yung cells. So, imbis na dumadami pa yung cells ng fetus, dumalaki na lang yung cell size mo. So, that's what we mean by hypertrophic. So, if the insult is after 20 weeks, the growth restriction could actually be asymmetric. And this is a summary table showing the symmetrical versus asymmetrical na growth ng fetus mo. So again, if your fetus is proportionately small, so all the parts are small, most likely the insult was done earlier in pregnancy as compared to a fetus na mas malaki ang head compared to your abdominal circumference. So usually, pag asymmetrical yung growth restriction mo and yung late yung insult mo, mas malaki yung head circumference mo compared to your abdominal circumference. And this is because we have brain sparing. So by brain sparing, it means that the fetus would prioritize yung blood supply niya, yung nutrition niya, would prioritize the brain. And because napaprioritize yung brain, other parts of the fetus would become small. So, pag may nakita kayong fetus na malaki yung ulo, maliit yung katawan, most likely the insult to that fetus is during late gestation. And for small for gestational age babies, you could start suspecting this if, for example, during your consults, you would notice that the fundic height is less than 3 centimeters than expected. Remember, as we said earlier in our first lecture, by 20 to 34 weeks age of gestation, dapat nagko-correlate yung fundic height mo with the age of gestation by your LMP or your early ultrasound. So, if during physical examination, malaki yung gap between your fundic height and your current age of gestation, that should give you a high index of suspicion na baka meron siyang SGA or IUGR, and maybe that should prompt you to have a scan done. Pero again, using the fundic height to screen for SGA and LGA only has less than 50% sensitivity and less than 50% positive predictive value. But still, it should prompt you to investigate further if meron ba tayong lag sa growth ng fetus natin. And for gravid women who have been diagnosed to have fetuses with small for gestational age babies, we should do serial ultrasound scans for growth monitoring every 2 to 3 weeks. And ang gusto natin sana is your ultrasound with Doppler study, especially of your umbilical artery, to differentiate it with small for gestational age baby with intrauterine growth restriction. So, for babies, for fetuses with IUGR, it usually starts off na yung indices mo in your Doppler would increase, and then eventually there would be a decrease in your end diastolic flow, and then after which there would be absent diastolic flow or reversal of your end diastolic flow. So, ang nangyayari sa IUGR babies, parang yung blood ng fetus ang bumabalik sa placenta. But that's not what we want. We want na yung placenta yung nagbibigay ng blood sa fetus natin. So, unlike small for gestational age babies with abnormal Doppler studies, kapag normal naman yung Doppler studies tapos small for gestational age lang, we can still manage these babies to term. Karamihan sa mga small for gestational age fetuses na normal naman ang Doppler value, especially here in the Philippines, they're just constitutionally small. So, maliit lang talaga yung nanay, maliit lang talaga yung tatay. But, kahit ganon, basta may SGA sila, dapat nagsiserial ultrasound tayo just to check for growth, for the growth of our babies and if nagde-develop siya ng abnormal Doppler studies. For babies naman na merong small for gestational age but with abnormal Doppler values, we usually deliver these babies earlier and expedite the delivery. So for large for gestational age fetuses naman, it's defined as those with an estimated fetal weight of greater than 90th percentile. Again, so if it's 90th percentile, that's LGA. Less than 10%, that's SGA. And macrosomia is defined as a birth weight of more than 4,500 grams. Yung mothers natin with large for gestational age or macrosomic fetuses have been found to have an increased risk for cesarean deliveries, perineal trauma dahil malaki si baby, as well as postpartum hemorrhage. So these are the usual etiologies of your large for gestational age fetuses. So of course, you have your gestational diabetes mellitus, those with pre-existing and current GDMs. May ilan sa kanila nagde-develop to LGA, but your GDM can actually produce small for gestational age babies as well. Maternal obesity, defined as BMI of greater than 30 or weight of 90 kilograms or more, have been associated with LGA. A history of LGA and previous delivery, post-term pregnancies, dahil syempre sobra-sobra na yung time nila dun sa uterus mo, multiparity, as well as advanced maternal age have also been found to be associated with your large for gestational fetuses. Okay, so for the diagnosis of LGA, same with SGA, during your examination on your consults, dapat nagsasuspect kayo for a possible large for gestational baby if the fundic height is greater than 3 centimeters than your expected age of gestation. However, for LGA as well as SGA babies, dapat bine-verify nyo rin yung pregnancy dating. And it has been found that majority actually of LGA diagnosed na pregnancies are actually because mali lang yung pag-date ng pregnancy. So, very important din talaga that we do a repeat ultrasound in the late trimester or pag near term na, especially in patients with diabetes mellitus or a previous LGA infant, to know the current estimated fetal weight of your baby before delivery. Kasi baka kailangang cesarean section or the like. So moving on to disorders of amniotic fluid. So at late gestation, the fluid regulation in your amniotic fluid is actually maintained by 4 forces. This would include fetal urination by your kidneys, intramembranous exchange, lung fluid production, and resorption via fetal swallowing. And among these, amniotic fluid is mostly produced from fetal urination. Kidney function begins at around 8 to 11 weeks age gestation but does not become a major pathway in amniotic fluid production until the second trimester. So, which is why yung fetuses natin with lethal kidney abnormalities early on in pregnancies do not present as oligohydramnios during the first trimester. Kasi by that time, hindi pa naman fetal kidneys ang main na nagpo-produce ng amniotic fluid natin. On the other hand, Resorption by fetal swallowing is the main pathway through which amniotic fluid is resorbed. So production, that's mainly by your fetal kidneys. Resorption, that's mainly by fetal swallowing. So, any abnormality in the said pathway sa kidneys nyo or sa gastrointestinal tract ng fetus nyo may cause disorders in your amniotic fluid volume. So, for example, if you do not have functioning kidneys, then you may have oligohydramnios, especially second trimester and above. And if meron ka namang blockage sa digestive system mo, such as in fetuses with esophageal atresia, you may have polyhydramnios. So how do we determine if we have oligohydramnios or polyhydramnios? We use your SDP or single deepest pocket or your amniotic fluid index. So this is a table summarizing the values from Williams as well as the POG-CPG on fetal growth disorders and abnormalities amniotic fluid volume. So by single deepest pocket, we mean that this is the vertical dimension of the largest pocket of amniotic fluid, not persistently containing umbilical cord or fetal extremities, measured perpendicular to the uterine contour. Okay? And for your SDP, the normal values of which would be 2 to 8. Yun ang alalahanin nyo, between 2 to 8. Same lang naman halos yan from between Williams and the POGs. Anything below 2 centimeters would imply that your baby has oligohydramnios, and anything beyond 8 centimeters could diagnose polyhydramnios. Polyhydramnios is divided into 3 parts. It could be mild, moderate, and severe, and the management of which would depend on the severity of your polyhydramnios and the etiology of your polyhydramnios. Amniotic fluid index naman is actually the summation of 4 single deepest pockets in 4 quadrants. So, kukuha ka ng single deepest pocket dito, yung SDP niya dito, plus dito, and dito, and the summation of which would be equivalent to your amniotic fluid index. And the normal range natin for your AFI is 5 to 24. Anything below 5 centimeters na AFI, that's oligohydramnios, and anything beyond 24 centimeters, that's polyhydramnios. This is a summary table found in your handout showing the usual causes of oligohydramnios and polyhydramnios. So according to the POG-CPG on your amniotic fluid disorders, there are 6 major causes of oligohydramnios, the first of which would be fetal abnormalities precluding normal urination. So kapag meron kang damage na kidneys early on, such as in patients with Potter syndrome, so natanong to in a previous PLE, that could predispose your pregnancy to oligohydramnios. Other causes would include your PPROM, which we discussed earlier, and actually your ruptured membranes is the most common cause of oligohydramnios. Kaya very important din, especially kapag late pregnancy, that you try to investigate if ruptured or not yung bag of waters. Kasi baka kailangan nating mag-initiate din na antibiotic therapy to prolong the latency of your pregnancy. Oligohydramnios may also be idiopathic or isolated. It can also be caused by uteroplacental insufficiency, such as in patients with preeclampsia, patients with multiple pregnancies, such as those with twin-to-twin transfusion syndromes. So in TTTS, dapat meron kang oligohydramnios and polyhydramnios. And lastly, it could be iatrogenic, such as in women na nagtitake ng medications affecting the kidneys. Polyhydramnios, on the other hand, may be idiopathic as well. And as we discussed earlier, it could be due to any congenital anomaly or genetic disorder that may affect yung resorption ng amniotic fluid mo. So if your GI tract is affected, if you have CNS abnormalities precluding you to have disorders in swallowing, that could also be a cause of polyhydramnios. And other neuromuscular disorders like hindi rin siya nagfi-fetal swallow. Yon. So that could be your usual causes of polyhydramnios kapag congenital anomalies ang pag-uusapan natin. Other causes would include diabetes mellitus, of course, from fetal polyuria due to hyperglycemia and increased osmotic diuresis. Multifetal gestation, such as in TTTS, fetal anemia, as well as placental tumors. So let's move on with RH incompatibility and alloimmunization. So what happens in RH incompatibility? So this occurs usually in a mother with an RH negative blood. So very important na we get your complete blood count with the RH. So, pag RH negative yung maternal blood mo and then you have a fetus with RH positive blood, during the first pregnancy, wala tayong problem. Because at that time, hindi pa sensitize yung maternal blood mo with your RH positive fetal blood. However, after delivery, kapag nag-rupture na yung membranes and na-expose na yung maternal blood mo to RH positive fetal blood, it gets sensitized and it would produce RH antibodies. So, come second pregnancy and come succeeding pregnancies with an RH negative mother na may RH antibodies at nagkaroon siya ulit ng RH positive fetus, the IgG antibodies in the mother would cross the placenta and would cause hemolysis of fetal RBCs. So that's what happens with RH incompatibility. Okay, so besides exposure to a fetus in a prior or current pregnancy na RH positive yung fetus, tas RH negative yung mother, sensitization to your RH antigen may also occur due to prior blood transfusion. So, yung sensitized patients mo with RH positive fetuses, again, the antibodies would cross the placenta and would cause hemolysis of your fetal RBCs. And the resulting anemia of which would increase extramedullary production of fetal red cells, which would eventually cause your erythroblastosis fetalis, also called your fetal hydrops. So, the anemia in these patients can cause symptoms with hyperdynamic state, high output, cardiac heart failure, diffuse edema, ascites, pleural effusion, pericardial effusion. Kaya hindi sila nagiging viable. Okay. Tapos, also important to know that ABO incompatibility actually decreases the risk of RH sensitization. So, if you have an RH negative patient with negative antibody screen, we try to avoid sensitization during pregnancy by administration of your ROGAM or your anti-D immunoglobulin or HIGG to be administered at 28 weeks and at postpartum if the neonate is RH positive. The standard dose of which would be 0.3 milligrams na RHIgG. Kaya very important talaga that we get your complete blood count early in your pregnancy so that we may administer ROGAM to these mothers na RH negative. Okay, let's move on to intrauterine fetal demise. So, IUFD or intrauterine fetal demise only complicates around 0.5 to 1% of pregnancies and is found in around 1 in 1,000 term births. Usually, ang IUFD, walang explanation and madalas sinasabi nila due to cord accident lang. And ang ayaw natin with IUFD is that we retain it greater than 3 to 4 weeks because there is high possibility for disseminated intravascular coagulation or your DIC. And it is due to hypofibrinogenemia secondary to the release of thromboplastic substances in your decomposing fetus. That is why for patients with IUFD, we admit these patients and we try to induce labor. So, nagsastart tayo ng oxytocin, we try to dilate their cervix para mag-labor sila at malabas nila yung fetus. Kasi ayaw natin umabot sa point na magkakaroon tayo ng DIC in patients with IUFD. So, that's how you manage it. So, for example, also, the reason why in patients with abortion, less than 20 weeks, di ba, tinatry din natin na kapag hindi nag-work ang expectant management through your medical management ng abortion, like yung Metrogen mo, misoprostol, if after 1 month of expectant management in abortion cases, we also do dilatation and extraction for patients na 12 to 20 weeks. And we try to open the cervix para malabas natin yung products of conception. Kasi abortion man yan or IUFD na more than 20 weeks, you're still at a higher risk for disseminated intravascular coagulation. Lastly, for fetal complications, we have postterm pregnancy, and it's defined as pregnancy beyond 42 weeks age of gestation or 294 days after your LMP. So only 3 to 10% of all pregnancies will go to postterm pregnancy. And actually, the most common cause of your postterm pregnancy is just inaccurate dating. Postpartum pregnancy has also been associated with overweight and obese women, as well as in fetuses with anencephaly, fetal adrenal hypoplasia, and absent pituitary glands. And it's because decrease yung hormones mo as well as your circulating estrogens that would cause labor. So for patients na may gantong fetuses, they have been found to be associated to progress more to postterm period, and labor induction may be required for them. For the management of postterm pregnancy, so we do increase surveillance starting 40 weeks, and we may actually start induction at 41 weeks age gestation para hindi na siya umabot ng 42 weeks. Moving on with multifetal gestation. So the rate of twinning is actually just 1 in 80% of pregnancies, and you can have dizygotic or monozygotic twinning. Pag dizygotic, from the name itself, you have two zygotes, so two different egg cells na maka-fertilize ng sperms. On the other hand, for monozygotic twins, you just have one egg cell fertilized by one sperm, and this egg would divide. So yun ang monozygotic and dizygotic. And more commonly, we would see dizygotic twins. Dizygotic twinning occurs in 70% of multiple gestations, even without considering yung assistive reproductive technology. But with ART, such as IVF and ovarian stimulation, these further increase the risk for dizygotic twinning. The frequency of your dizygotic twins is lowest actually in Asians, intermediate in Caucasians, and higher in African Americans. So dizygotic twinning has also been shown to be familial, kaya mas ito yung common compared sa dalawa. For monozygotic twinning, the number of chorions and amnions would depend on the day of division post-fertilization. So if the separation of the two would occur before differentiation of your trophoblasts, you would produce 2 chorions and 2 amnions, and this would be your dichorionic, diamnionic gestations. And this occurs within 0 to 4 days or within the first 72 hours if according to Williams. However, if the separation would occur after trophoblastic differentiation but before amnion formation, you would have 1 chorion but 2 amnions. So this is your monochorionic diamnionic, and it's found in patients na ang division post-fertilization is after 4 to 8 days. Ang division naman after amnion formation would lead to a single placenta, 1 chorion, and 1 amnion. And this is your monochorionic, monoamnionic pregnancies. And this is said to occur from 8 to 12 days post-fertilization. And the most rare of all would be those na magsiseparate beyond 13 days age of gestation. And for these patients, you would produce conjoined twins or your Siamese twins. Sa mga ito, ang at a higher risk ka for your twin-twin transfusion syndrome would be those pregnancies with 1 chorion. So your monochorionic diamnionic and your monochorionic monoamnionic. Majority of which would occur in your monochorionic diamnionic pregnancies. But your TTTS may also occur in your monochorionic monoamnionic pregnancies. And we will discuss TTTS later. So, for the diagnosis of twin pregnancy, for your dichorionic diamnionic pregnancies, you would see the twin peak sign, also called as your lambda sign, in which you would see an intervening membrane of more than or equal to 2 millimeters. For monochorionic diamnionic pregnancies, you would see your T sign in the ultrasound, and for which your intervening membrane is less than 2 millimeters. For monochorionic, monoamnionic, as well as for conjoined twins, in the ultrasound, there would be no intertwin membrane. So, paano ba natin dinedeliver ang twin gestations? So, automatically, for monochorionic, monoamnionic, as well as for conjoined twins, for triplets and above, we do cesarean delivery due to a lot of fetal complications that could happen if we do vaginal delivery. Kapag dichorionic, diamnionic, as well as monochorionic, diamnionic, we can opt to do trial of labor depending on the presentation. So, if the presenting part is breech, automatically, we would prefer a cesarean delivery. But if sabihin natin yung presentation mo is cephalic, both of your babies are in the vertex presentation, you may do trial of labor. If it's vertex breech, you may also do trial of labor if the presenting twin is larger. And if the presenting twin is larger, it would mean kasi na kasya yung fetus dun sa pelvis mo. And it would be possible to do breech extraction of the second twin. Kasi imagine if yung second twin mo yung mas malaki, tapos lumusot na yung maliit, tapos yun pala, hindi siya kasya. So, hindi natin siya madedeliver. Magsi-CS ka rin eventually. Okay. So, twin-twin transfusion syndrome, for twin-twin transfusion syndrome, it's secondary to an equal flow within the vascular communication between twin A and twin B. So, for this syndrome, meron kang isang donor twin at meron kang isang recipient twin. And the management of which would depend on the stage based on your Quintero staging. So, you may do serial amioreduction dun sa twin mo na may polyhydramnios, if needed, and sometimes laser coagulation of vascular connections is also done. If it's very severe, mga stage 4 na TTTS, termination is an option if severe. So, madali lang i-memorize actually itong Quintero staging. Isipin nyo na lang, stage 1, bladder is visible. Yun ang important. For all cases of TTTS, dapat meron kang isang twin na may oligohydramnios at isang twin ay may polyhydramnios. Okay? So, stage 1, bladder is visible. Yun lang isipin nyo. Stage 2, bladder is not visible. Stage 3, meron ka ng any Doppler abnormality. So, that would include absent or reverse end diastolic velocity sa umbilical artery, reverse flow sa ductus venosus, as well as pulsatile umbilical venous flow. Any Doppler abnormality, stage 3. Stage 4, meron ka ng fetal hydrops in the recipient twin. Stage 5, meron kang fetal demise, whether it's both twins or a single twin. So, stage 1, bladder is visible. Stage 2, bladder not visible. Stage 3, Doppler abnormality. Stage 4, hydrops. Stage 5, fetal demise. Okay, so that's your TTTS. And your TTTS is not the same with your twin-twin discordance. So, pwedeng meron kang twin-twin discordance pero wala kang twin-twin transfusion syndrome. Pag TTTS, dapat meron kang oligopoly. Pag twin-twin discordance, kailangan lang malaki yung difference between their weights. And by malaki, the significant or cutoff for significant differences in the weight would be more than 20%. And the formula of which for twin-twin discordance is the weight of the larger twin minus the weight of the smaller twin over the weight of the larger twin. So let's move on with obstetric hemorrhage. So obstetric hemorrhage encompasses both antepartum and postpartum hemorrhages. For obstetric causes, antepartum, we usually, ang most common would be your abruptio placenta na 30% and then followed by placenta previa. Other rare causes of obstetric hemorrhages would be your vasa previa and uterine rupture. Non-obstetric causes na found antepartum would be lacerations as well as hemorrhoids. For postpartum, you can differentiate it between early versus late postpartum hemorrhage. And ito yung meron tayong 4Ts, your tone, tissue, trauma, and thrombin. The most common cause of postpartum hemorrhage would be your uterine atony. So let's begin with some of the causes of your obstetric hemorrhage, starting with placenta previa. So placenta previa is defined as the presence of placental tissue extending over or lies proximate to the internal cervical os. And for placenta previa, yung bleeding nyo would occur when the lower uterine segment would form and the cervix would eventually dilate, applying shearing forces to the inelastic placental attachment site. Bleeding is also augmented by the inherent inability of the myometrial fibers in the lower uterine segment to contract and constrict the torn vessels. So, di ba, placenta previa, malapit siya sa os. And yung main source natin ng uterine contractions during pregnancy would come from the fundus. So, normally or essentially, hindi maganda yung contraction with that in that area sa lower uterine segment. So, maliban sa nagkakaroon ka ng cervical dilatation and LUS formation na prompting the shearing forces, hindi rin talaga effective yung muscles in that area to constrict. So, talagang magbi-bleed ka. Okay? So, the most common symptom of placenta previa would be painless vaginal bleeding. And bleeding from placenta previa may be provoked by sexual intercourse. For placenta previa, our gold standard for the diagnosis would be ultrasound, wherein we visualize the placenta at or near the internal os. And the sensitivity and specificity of your transvaginal ultrasound in diagnosing placenta previa can go as high as 99%. So you have 3 different types of placenta previa. The first of which is placenta previa totalis, meaning completely covering the os, yung placenta. For placenta previa partialis, the internal os is only partially covered by a part of the placenta, while for low-lying placenta, your placenta is implanted in the lower uterine segment, but the edge is more than 2 centimeters from the internal os. So, malapit lang siya dun sa internal os, within 2 centimeters from the internal os. We have several risk factors for placenta previa, such as advanced maternal age, multiparity, uterine surgeries, recurrent abortions, structural abnormalities in your uterus, ART, infertility treatments, among others. And the management of which would differ depending if your patient is bleeding or not. If meron kang uncontrolled bleeding, whether or that's a preterm or a term patient, tas uncontrolled yung labor, tas significant bleeding, or you have unstable fetal or maternal status, automatically we deliver via cesarean section. If you have preterm or term with no active bleeding, very minimal bleeding, controlled yung bleeding, no active labor, for these patients, we may do expectant management. And for preterm patients na sabi natin threatened preterm labor, we may do tocolysis, but it's only recommended for 48 hours. Again, so that we may give your single course of antenatal steroids. For patients also with placenta previa, kapag hindi sila in labor, it's recommended actually that we give them a single course of antenatal steroids between 34 to 36 and 6 weeks. And before 34 weeks, if meron silang higher risk of preterm birth. For these patients as well, if stable, we do elective scheduled cesarean delivery. According to the Society of Maternal Fetal Medicine, we do it between 34 to 37 weeks. But according to the POGS 2019 CPG on third trimester bleeding or obstetric hemorrhage, we do it at 36 to 37 weeks. So the management of placenta previa is very individualized, and you would need to consider fetal maturity, associated labor, and bleeding severity. But in general, ito yung summary table natin for its management. Okay, so the risk of your placenta accreta spectrum is increased in patients with placenta previa in the setting of a prior cesarean delivery. And in the setting of current placenta previa, the concurrent risk for ACRETA increases after every cesarean section. So after 1, that's 3%. After 2 CS, that's 11%. And as you can see, after 5 CS, that's as high as 67%. So very important for patients na may history of hysterotomy, history of cesarean section, with placenta previa, rule out placenta accreta spectrum. So what is placenta accreta spectrum? It's defined as abnormally adherent villi to the myometrium due to the partial or total absence of your decidua basalis layer, or the imperfect development of your fibrinoid or your Nitabuch layer. So for placenta accreta spectrum, you may actually have total placenta accreta, meaning the whole of your placenta is adherent, involving all cotyledons. Pwedeng partial lang, so meron lang few or several cotyledons that are abnormally adherent to the myometrium. And you may also have focal placenta accreta, so meaning you only have a single cotyledon abnormally attached to the myometrium. So you have 3 types sa spectrum. You have accreta, increta, percreta, the most common of which would be accreta, composing 75% of the spectrum. And it's the less severe of them all. So ang important lang dito is you remember the first letter of the type. So pag accreta, it's just attached to the myometrium. If it's increta, it invades the myometrium. If it's percreta, it already penetrates to the myometrium to and through the serosa. So, syempre, less severe, mas common, more severe, less common. And these are the usual ultrasound findings that you would see in patients with accreta spectrum disorders, which you would try to look for antenatally. You would find loss or irregularity of your retroplacental clear zone, abnormal placental lacunae, bladder wall interruption, myometrial thinning, placental bulge, and focal exophytic mass. So itong mga ultrasound findings na to, you could see even in your 2D ultrasound. And the ultrasound finding with the highest positive predictive value would be your bladder light interruption. Yung abnormality ng uterus to bladder interface mo has the best specificity, as high as 99.75%. And for the diagnosis of your placenta accreta through your scan, your color Doppler is a reliable method for the detection, especially of your bladder invasion in patients with placenta percreta. So, once diagnosed also, you should do serial ultrasound evaluation to determine placental migration, location, and progression to bladder invasion. It's also very important that you repeat your scans and do a placental mapping prior to surgery to identify the placental borders and to be able to determine where to incise during your OR. Kasi syempre, ayaw natin na mahiwa yung placenta habang nag-hysterotomy kasi magiging sobrang madugo yun. And for patients na may high suspicion ka na possible magkaroon ng accreta, such as yun nga, patients natin with placenta previa, previous CS, previous hysterotomy, as early as the 2nd trimester, you should rule out accreta spectrum. Okay? Management of placenta accreta, we also administer corticosteroids between 24 to 34 weeks, especially for those women with an increased risk of pregnancy within 7 days. If with significant bleeding and uterine contractions, same as your placenta previa, immediate delivery. For asymptomatic patients, di nagbe-bleed, wala, you do elective delivery at 34 to 35 and 6 weeks after giving corticosteroids. So, very important in planning for the elective ORs of patients with placenta accreta that you do it with a multidisciplinary team because pwedeng madikit siya, so it may involve urocervix, especially if it's percreta, affecting the bladder. You may call gyne-onco, and syempre since we're delivering a preterm delivery, dapat coordinated ito with pediatric service. In fact, for elective cesarean hysterectomies, which is the definitive management for patients with Akreta spectrum disorders, the estimated blood loss for CSS hysterectomy is around 2 to 5 liters. So talagang pinaplano nyo dapat yung OR for the CSS hysterectomy. Dapat nagre-reserve ng blood as much as 4 to 6 units of your RBC, FFP, and platelets. And yung ratio na ginagamit natin for massive blood transfusion would be 1:1. So RBC to FFP, 1:1. You may do conservative management for focal cases of placenta accreta, but very important that you select your patients well. In conservative management of your placenta accreta, we leave the entire placenta or the part that is adherent to the myometrium in situ to preserve the uterus. In some patients, we leave the placenta and then we do delayed or late postpartum hysterectomy. Usually 3 to 12 weeks after. So, pwedeng ganun din. So, next pathology is placenta abruptio or your abruptio placenta. So, abruptio placenta is defined as the separation of your placenta either partially or totally from its implantation site before delivery. Abruptio likely begins with the rupture of your decidual spiral arteries and succeeding hemorrhage into the decidua basalis. This the subsequent expanding of your retroperitoneal hematoma in abruptio placenta would split the decidua, and then it would leave a very thin layer adherent to the myometrium. The decidual hematoma would grow to lift away, and it would then compress the adjacent placenta. So, ang placenta abruptio, it may be concealed and it may also produce external hemorrhages. So, external hemorrhages is more common, and at ito yung madalas natin na-diagnose dahil meron silang vaginal bleeding. Pero for patients with concealed hemorrhages, ang pangit sa mga patients na to, there could be delayed diagnosis since there's no vaginal bleeding, and sometimes this may translate to greater maternal and fetal hazards. So, placenta abruptio, 50% of which would occur before labor and after 30 weeks. So, it's actually common in late pregnancy and preterm babies and preterm pregnancies, kaya after 30 weeks. 15% of which have been found to occur during labor, while 30% of which are incidental finding na makikita na lang on placental inspection na, ay, abruptio pala to. So, abruptio placenta, the diagnosis of which is actually clinical, and it should be suspected in patients who classically present with sudden onset abdominal pain, vaginal bleeding, especially in the third trimester, uterine tenderness. Other presentations would include non-reassuring fetal heart traces. In fact, 60% of patients would present with non-reassuring fetal heart traces. They could also present with frequent and strong contractions and persistent hypertonus. Okay. For patients, some patients though would be asymptomatic or with very few symptoms. But classically, this is the presentation of abruptio placenta. And hindi natin kailangan ng ultrasound, hindi natin kailangan ng histopathologic diagnosis to say na abruptio to, because if you're suspecting abruptio clinically, you should do immediate delivery of your baby. So for abruptio placenta, the most important risk factor and the risk factor with the strongest association will be a history of a previous abruptio. In fact, the risk of abruptio in a future pregnancy is 10% after one abruptio and increases to 25% after two abruptios. So our next pathology for obstetric hemorrhage would be your uterine rupture. Uterine rupture only occurs in 1 in 15,000 to 20,000 of deliveries in patients with no history of uterine surgery. But with those with prior hysterotomy, such as in patients with cesarean sections, the risk for uterine rupture is high. So, pag classical cesarean section, the reason why we do not do trial of labor after cesarean delivery in a patient with a previous classical cesarean section is because the risk for uterine rupture is as high as 6 to 12%. But for patients na low transverse cesarean section at isa lang, the risk is only 0.5 to 0.1%. But for patients na dalawa yung low transverse cesarean section, some institutions hindi na sila nagpapa-TOLAC or VBAC because the risk for uterine rupture is also higher. So for the diagnosis of uterine rupture, the classical history of patients with uterine rupture would present with the fetal heart rate decelerations and with those with prior hysterotomy. On history, sasabihin lang na para may narinig sila na sudden popping sensation and sudden abdominal pain. So if you're presented with a patient na may vaginal bleeding in the 3rd trimester with abdominal pain, think abruptio placenta or uterine rupture. On physical examination though of your uterine rupture compared to your abruptio placenta, usually yung fetal parts nyo napapalpate nyo na on your Leopold's maneuvers. So, yung presenting part nyo masyadong mataas kapag nag-IE kayo, like higher station than the usual, and sometimes you could palpate nga yung fetal parts niya dun sa abdominal space kasi nag-rupture na yung uterus. And again, there's possible vaginal bleeding. So the management of your uterine rupture is to do immediate laparotomy and delivery of your fetus. And for patients who are at a higher risk of uterine rupture, such as yun nga yung mga patients natin na may previous classical cesarean section or more than one low transverse cesarean section, let's avoid TOLAC and we do delivery of the pregnancy via repeat cesarean section between 36 to 37 weeks. Actually, hindi naman kailangan na ganun kaaga. Pero we do elective RCS. Lastly, for 3rd trimester bleeding, we have vasa previa. Vasa previa is defined as fetal vessels overlying the cervical os, and by convention, the presence of aberrant blood vessels within 2 centimeters from the internal os is also considered to have similar implications as the vessels actually covering the os. So again, these are fetal vessels. This is different from your umbilical cord. Fetal vessels ang nag-overlay sa os in vasa previa, not your umbilical cord. And since in vasa previa, kapag napunit mo yung fetal vessels, the blood affected is fetal and not maternal as compared to your other pathologies discussed a while ago. There would be rapid exsanguination of your fetus. And itong incidents na pwedeng maputol yung fetal vessels, they may be torn during cervical dilation or membrane rupture. Kapag nag-compress also yung presenting part mo dun sa fetal vessel. So, pag may compression, pag may cervical dilation, or during fetal rupture, dun pwedeng mapunit yung fetal vessels mo. So, in the absence of prenatal sonographic diagnosis, and actually, we rarely diagnose vasa previa via ultrasound, pero possible, pero compared to your other causes of 3rd trimester bleeding, it's not as common. So, in the absence of prenatal sonographic diagnosis of your vasa previa and in the presence of ruptured membranes, tapos upon rupture, napansin nyo nagkaroon ng sudden vaginal bleeding na sobrang dami, tapos bigla ka nagkaroon ng fetal heart rate abnormalities, suspect vasa previa. Kasi pag nag-rupture ka ng membrane, remember, pag nag-rupture ka, pwedeng bumaba yung fetal part at pwedeng makompress yung fetal vessels. So, that would cause the rupture of your fetal vessels. So, risk factors for vasa previa would also include low-lying placenta, multiple pregnancies, and in vitro fertilization. So, for vasa previa, you actually have 2 parts. So, ganito muna yung normal natin na umbilical insertion. So, dapat paracentrally yan. But, in the first type of vasa previa, the vessels are part of a filamentous cord insertion. And by filamentous, we mean that parang filamentous from the word veil-like. So, it's a abnormal it's an abnormal condition in pregnancy in which the umbilical cord would insert first dun sa fetal membranes. So, hindi siya diretso dun sa placenta. Dun siya sa fetal membranes, and then, since nandito yung umbilical cord, the vessels from the umbilical cord would then travel within the membranes to the placenta. So, marami kang exposed vessels dun sa area na to kung saan hindi nakakabit agad yung umbilical cord mo sa placenta. So, ito yung sample photo of placenta with filamentous cord insertion. So, as you can see here, this is the umbilical cord. Tapos, it stops here. Oh. Pagdating dito sa membrane na to, it already divides to fetal vessels. And kapag itong area na to yung naipit dun sa opening ng cervix mo at nag-compress dyan yung presenting part, it could cause fetal vessel rupture. Yan. So, ito yung sample diagram natin of your type 1 vasa previa. The second type of vasa previa would come from vessels spanning between portions of a bilobate or a succensurate lobe. So, ibig sabihin, meron kang dalawang placenta, tapos, syempre, meron ka lang isang umbilical cord na usually implanted siya centrally dun sa main mo na placenta. And then, the vessels from there would have smaller vessels that would supply the more distant smaller lobe. So, itong area na to, yan na at risk for fetal vessel rupture. And again, since it's fetal blood loss ang nawawala and it may cause rapid exsanguination of your fetus, you do emergency cesarean section. And if you can diagnose this vasa previa antenatally, which is good, you should do elective cesarean section. Okay, let's move on with hypertensive disorders in pregnancy. So, ano ba ang pathogenesis natin ng preeclampsia? So, this is a schematic presentation of normal placental implantation here, showing the proliferation of your extravilous trophoblasts from an anchoring villus. These trophoblasts would invade the decidua and would extend into the walls of the spiral arterioles here, to replace the endothelium and the muscular wall to create a dilated low resistant vessel in your normal pregnancies. With preeclampsia, there is defective implantation of your there's defective implantation characterized by incomplete invasion of the spiral arteriolar wall by your extravilous trophoblasts. So, yun ang pathogenesis natin for preeclampsia. Abnormal, defective implantation, and incomplete invasion of your spiral arteriolar wall by your extravilous trophoblasts. So, dahil defective yon, it would result in smaller caliber vessels causing high resistance to flow. Kaya tumataas yung blood pressure mo. So, gestational hypertensive disorders are actually more likely to develop then in women with exposure to chorionic villi for the first time, exposure to superabundance of chorionic villi as in cases of multiple gestations or molar pregnancies, hydatidiform moles. More women are also associated with gestational hypertensive disorders if they have pre-existing conditions associated with endothelial cell activation or inflammation. So this is disease-related. And lastly, if they have genetic predisposition to hypertension. So, review of the definitions of our different hypertensive disorders in pregnancy. If meron kayong topic na kailangan alam na alam in OB, it would be hypertensive disorders in pregnancy. Never nagkaroon ng PLE na walang question about this, and they would usually ask case questions starting from the diagnosis of the case up to the management of the disorder. So, chronic hypertension is defined as BP elevation of 140 to over 90 before 20 weeks age gestation, or BP elevation more of 140/90 beyond 12 weeks postpartum. So, pwedeng nag-elevate siya during pregnancy but hindi na siya bumaba 12 weeks postpartum. So, automatic chronic hypertension na yon. For gestational hypertension, it's new onset BP elevation after 20 weeks age of gestation in a previously normotensive woman. And your BP is supposed to return to normal values within 12 weeks postpartum. Preeclampsia naman is hypertension with proteinuria, and by proteinuria, we defined it through either of the three parameters, and the most ideal of which would be your 24-hour urine protein that's that would measure 300 milligrams or more. Pero kung wala ka nun, an easier way would be to get your urine protein creatinine ratio, and it should be more than or equal to 0.3. And lastly, you can also use dipstick or your urinalysis, and kung persistently meron kang protein na 1+ in your urine, you can also diagnose preeclampsia. Although using your dipstick is not the most ideal method in diagnosing proteinuria, but in cases kung kuwari you're in a far away land na wala masyadong laboratory test and you only have your dipstick to check for proteinuria, then you can already diagnose preeclampsia through that. Pero if you have your 24-hour urine protein or your urine protein creatinine ratio, that would be better. Yung preeclampsia natin, you can further differentiate it between your with or without severe features. Anything with the following features would predispose the patient to preeclampsia with severe features. So, kapag meron kang platelet count na less than 100,000, your serum creatinine concentrations of more than 1.1 milligrams per deciliters or twice your baseline in the absence of any renal disease, as well as twice your baseline ALT and AST, new onset pulmonary edema, and new onset cerebral or visual symptoms. Automatic, that's preeclampsia with severe features if you have hypertension plus proteinuria. But also, in the absence of proteinuria, new onset hypertension with new onset of any of the following could already diagnose a patient with preeclampsia with severe features. For severe range blood pressure, that's 160/110 millimeters mercury. Remember, for the diagnosis natin ng gestational hypertension, yung new onset natin na BP elevation should be measured twice. So, dapat meron kang 2 elevations 4 hours apart. But for patients na severe range ang blood pressure, that's 160/110, a short interval to confirm kung talagang mataas yung blood pressure may already suffice. So, hindi mo kailangan maghintay ng hours to diagnose preeclampsia in those patients. Pwede na yung 15 minutes. In Williams, it's 15 minutes. If it's severe range blood pressure, it should be confirmed within 15 minutes to be able also to facilitate anti-hypertensive therapy very early on. So, if you already have hypertension before the pregnancy or before 20 weeks age of gestation, but you have new onset proteinuria or new onset severe features, that would be your chronic hypertension with superimposed preeclampsia, with or without severe features. And then you also have eclampsia, which is the occurrence of your convulsions not caused by coincidental neurologic diseases in a woman with preeclampsia. So, review lang ng timing of delivery natin for patients with hypertensive disorders. Ultimately, the management of preeclampsia is the delivery of your fetus and your placenta. So, yun ang pinaka-management natin for preeclampsia. For gestational hypertension, as well as for preeclampsia without severe features, we may deliver at 37 weeks. For preeclampsia with severe features na hindi controlled, we can deliver as early as 34 weeks. Kapag nag-eclampsia yung patient, we deliver regardless of AOG. And then, if it's chronic hypertension na uncomplicated, pwedeng later on, as late as 38 weeks. If it's chronic hypertension with superimposed preeclampsia, we still follow the timing of delivery for your preeclampsia, so that's 37 weeks. If with severe features na chronic hypertension with preeclampsia with severe features, we still follow yung delivery for preeclampsia with severe features na uncontrolled. So that's 34 weeks. So bakit mas late, pwedeng mas late with chronic hypertension kahit mas matagal na silang hypertensive? It's because your mother is already used to the environment ng hypertension. At the same time, iba ang pathophysiology ng chronic hypertension with preeclampsia. Remember, preeclampsia, we said earlier, is a placental disorder involving your placental trophoblast. So talagang yung management mo would be the delivery of your placenta, since your pathogenesis involves the placenta. Unlike chronic hypertension is a systemic disorder. So kahit nanggaling mo yung placenta, it wouldn't resolve your chronic hypertension. So you can deliver these patients later on. So, for patients din na kailangan na natin i-deliver based on this, there is no need for immediate cesarean delivery unless there's an indication for it, such as your deteriorating maternal status. So, kung wari uncontrolled talaga yung BP elevations, hindi bumababa from 160 over 110 or more, despite hydralazine, despite all the medications you put, or pag may eclampsia, or pag or if you have non-reassuring fetal status, yun, so proceed with cesarean delivery. But if without those indications, you may do induction of labor. So HELP syndrome is would mean your hemolysis and elevated liver enzymes and low platelets. Pag meron ka ng HELP syndrome, the diagnosis of which you can see in your handout, you deliver if you get HELP syndrome beyond 34 weeks, you deliver after maternal stabilization. But if it's less than 30 weeks age of gestation ka nagkaroon ng HELP syndrome, you may deliver 24 to 48 hours after the administration of your corticosteroids, not necessarily betamethasone, pwedeng dexamethasone, and magnesium sulfate for neuroprotection and actually even for prevention of eclampsia. Eclampsia. So, eclampsia, again, so ito yung seizures natin associated with pre-eclampsia in a patient without any neurologic problems. So, your eclampsia may develop before labor, 59% of which would develop before labor, 20% during labor, and 21% after delivery. And for those na nag-occur after delivery, most of the seizures would occur within the first 48 hours after delivery, which is why we extend yung magnesium sulfate natin to 24 hours after delivery. So, complications of eclampsia would include placenta abruption, neurologic deficits, aspiration pneumonia sa mother, pulmonary edema, cardiopulmonary arrest, AKI, and even death. Kaya dapat talaga we do our best to prevent eclampsia. So, for the management of eclampsia, for seizure management, of course, very basic. You start with your ABCs, airway, breathing, circulation, and our first line anticonvulsant for eclamptic seizures is magnesium sulfate. So again, if it's an eclamptic seizure, it's magnesium sulfate, not diazepam. For BP control, syempre, kailangan pa rin natin control yung BP. So, we use hydralazine, labetalol, and actually nifedipine. So, yun yung 3 natin na ginagamit for severe preeclampsia and for the management of eclampsia na BP control. If there are further convulsions, the prophylaxis, the main pa rin would be your magnesium sulfate. But if hindi siya effective, that's when you can use your diazepam and other anti-seizure medications. And of course, like your preeclampsia, the delivery of fetus is also one of the things that we should do in patients with eclampsia. Kasi nga, ultimately, the management of preeclampsia is delivery of the fetus and the placenta. Okay, so how do we prevent eclampsia? We prevent it through the administration of magnesium sulfate. And for patients na diagnosed with preeclampsia, we already start them on magnesium sulfate for seizure prophylaxis at a dose of 4 to 6 grams loading dose, followed by 1 to 2 grams per hour through 24 hours postpartum. So, until 24 hours post-delivery. And, lagi natatanong to, the therapeutic seizure threshold would be 4.8 to 8.4 milligrams per ml. So, that's our therapeutic level for seizure prophylaxis. Very important also to note that monitoring for magnesium sulfate toxicity should be done in all patients na binibigyan natin ng magnesium sulfate. It is done through checking of your patellar reflexes. And at 10 mex per liters, we start losing the deep tendon reflexes. So magnesium intoxication is unusual when your glomerular filtration rate is normal or only slightly reduced. So we only do serial serum magnesium monitoring in patients with renal disease. So kapag okay naman yung patient, wala siyang renal disease, patellar reflexes lang ang ginagawa nating monitoring. And this is also the reason why we should monitor your urine output accurately, because kung meron kang adequate urine output, it would already imply that your GFR is okay. And you won't have to monitor for serum magnesium serially. Also important, kung bakit natin minimeasure yung urine output is because your parenterally administered magnesium is cleared almost totally by renal excretion. And magnesium clearance rate is approximately a third of your GFR determined by your creatinine clearance. So in cases of toxicity, kung talagang masobran sa magnesium sulfate, the antidote of which would be to give calcium chloride or calcium gluconate IV, 10 ml in 10%, both agents are cardioprotective. And itong slide na to, actually, lahat yan natanong na sa PLE, therapeutic threshold, anong ginagamit sa monitoring, anong ginagamit sa magnesium sulfate toxicity. So again, very important for you to know and to know by heart yung hypertensive disorders. Okay, so let's move on with diabetes mellitus in pregnancy. So, normal pregnancy is actually defined as a state of mild fasting hypoglycemia, postprandial hyperglycemia, hyperinsulinemia, and enhanced insulin resistance. So, these various mechanisms are set into motion in order for the supply of glucose to the fetus to be adequate and maintained throughout the pregnancy. So, maternal insulin resistance would actually result from increased placental secretion of diabetogenic and lactogenic hormones, especially your human placental lactogen or your HPL. So yung HPL natin, it's also called as your human chorionic somatomamotropin or your HCS, somatomamotropin, which is an insulin antagonist. So we discussed this a while ago in the first lecture. And since it's an insulin antagonist, you have a diabetogenic effect. And the effect of which would be to increase your insulin resistance and generally, meron kang carbohydrate intolerance. Yung HPL nyo rin, this would aid in the lipolysis so that you will have extra energy for your fetus. So, very important that we try to diagnose diabetes mellitus early in pregnancy because it has a lot of fetal and maternal complications. So, sa fetus, you can have macrosomia, but you can also have IUGR and SGA. You can have delayed organ maturity and intrauterine death, as well as congenital malformations. So, especially in those patients na may diabetes mellitus prior to pregnancy na uncontrolled, they're at a very high risk for congenital malformations, especially for cardiac anomalies. Kaya, for diabetes patients in pregnancy, na overt DM or may pre-gestational diabetes mellitus, we should request for a congenital anomaly scan in the second trimester to make sure that there are no congenital malformations. Very important also in diabetes mellitus na dahil sa fetal comorbids niya na pwede kang magkaroon ng intrauterine death all of a sudden. Sin maraming cases na gano'n na sobrang okay lang ng baby tapos bigla na lang hindi na wala na heart rate. For DM, this is actually an indication for testing for your biophysical profile and your NST early. Remember, we do not do your BPS and NST for low risk pregnancies kapag before 40 weeks. Usually we just do it at 40 weeks. But for diabetes mellitus patients, we do it earlier, and we do it on a weekly or 2 weekly basis. Maternal comorbids associated with diabetes insipidus. This would include polyhydramnios, preeclampsia. You can also have diabetes mellitus emergencies, vascular and organ involvement, as well as neurologic involvement. So itong mga to, itong vascular and organ involvement, as well as neurologic involvement, they're more also common in patients with overt DM as well as with pregestational diabetes mellitus. So for the screening of diabetes mellitus, both in Blueprints and in Williams, we do it at 24 and 28 weeks age of gestation. And at this time, mas mataas na yung levels ng HPL natin. So really at that time, we would expect insulin resistance. Sinama lang namin to kasi yun nga, sabi nila may ibang exams na Blueprints based. In Blueprints, they do a 50-gram glucose loading test first. So fasting and 1 hour after. And if it's elevated, they would proceed to a 75 or 100-gram glucose tolerance test. But of course, that's not what we usually do in the Philippines. And for high-risk individuals, we screen early in pregnancy. So ang first screening natin is FBS based on our guidelines. So all Filipino gravidas are considered high risk by race or ethnicity. And by race or ethnicity, that's because we're Pacific Islanders. So all Filipina gravida should be screened with an FBS, HbA1c, or random blood sugar during the first prenatal consult. But if there are other risk factors for gestational diabetes mellitus earlier in pregnancy, such as in patients with a family history of diabetes mellitus, in patients with a history of gestational diabetes mellitus in a previous pregnancy, obese women, those with polycystic ovarian syndrome, yung mga yon, immediately during the first prenatal consult, wag yun na ipag-FBS. You already check for the 75-gram OGTT. First consult pa lang. So if with no other risk factors after testing for the fasting blood sugar, if it's normal, we repeat the 75-gram OGTT at 24 to 28 weeks. Yon. So ano nga ba yung mga cutoff values natin for GDM? Ito na yung pinakita kong slide compared to a while ago. Mas madali ma-memorize from here. For overt DM, the diagnosis of which, pag FBS mo is more than 126 na, even on sa first prenatal checkup, that's already your overt DM. If you have an HbA1c of 6.5, a random blood sugar of more than 200 milligrams per deciliters with symptoms of diabetes mellitus, or a 2-hour OGTT level of greater than 200 milligrams per deciliters. So as you can see, these are also the cutoff values for your type 2 diabetes mellitus. For GDM, we diagnose GDM in patients with a fasting blood sugar of more than 92 but less than 126, and 1-hour OGTT of greater than 180, and 2-hour OGTT of greater than 153 but less than 200. And for self-monitoring of your blood glucose, so syempre pag meron kang GDM, unfortunately for these patients, we do serial CBG monitoring, and we have also different cutoff values. The CPG would recommend that a fasting blood glucose would be less than 95% pag fasting. 1-hour postprandial of less than 140, and 2-hour postprandial of less than 120. Okay? So, ito yung goals natin, and if 25 to 30% of your sugars during your monitoring are elevated, we already start them on insulin. But if not, they're technically diet controlled, and we do not have to start them with any medical treatment. In fact, the first line management for gestational diabetes mellitus would be medical nutrition therapy, or MNT. And ADA recommends a diet plan of 2,200 calories per day with 30 to 35 calories per kilogram of ideal body weight. So kapag controlled naman yung sugars mo, we do not have to give insulin, we do not have to give any other medications, just diet. Control the diet. But again, if hindi natin nami-meet yung cut-off values natin, if more than 25 to 30% of your total sugars are elevated, then we start them on insulin. And insulin is the first line management for gestational diabetes mellitus. For patients na uncontrolled ang fasting blood sugar, so we give them intermediate acting insulin or long acting insulin. So sa gabi siya binibigay. As compared to patients na yung postprandial glucose ang elevated, we give them short acting insulin pre-meals. Okay? Gets ba yun? So pag fasting ang elevated, we give them insulin na intermediate acting or long acting sa gabi bago matulog para bumaba yung fasting sugars nila in the morning. If postprandial ang elevated, we give them fixed doses pre-meals na short acting para yung postprandial ay hindi elevated. Metformin is not the first line management but may be given for patients with gestational diabetes mellitus. For the delivery of gestational diabetes mellitus, we induce labor at 39 weeks, but if with poor glycemic control, we can deliver as early as 37 weeks. So 37 to 39, pwede na if with poor glycemic control. If the patient is currently on insulin, these are discontinued, but the blood glucose should be monitored every hour. And for patients na may macrosomic babies, if the EFW is greater than or equal to 4,500 grams, we may do immediate or elective cesarean delivery. In the Philippines, actually, ang cutoff lang natin is 4,000 grams kapag meron kang gestational diabetes mellitus to proceed with cesarean delivery because Filipinos are smaller than Western women. Postpartum, very important that we repeat your 75-gram OGTT at 4 to 12 weeks. And if normal, we do it at least every 3 years because it has been found that 25 to 35% of patients na nagkaroon ng GDM during the pregnancy would develop overt diabetes within 5 years from that pregnancy. Also, it has been found that 50% of which, yung mga nagkaroon ng GDM, would have subsequent gestational diabetes mellitus in their next pregnancies. So, very important, we do your repeat OGTT, 4 to 12 weeks postpartum. Let's proceed with medical complications in pregnancy. Some of the medical complications in pregnancy. So first is your urinary tract infection, and the diagnosis of which will be the presence of 100,000 colonies on your urine culture. So kapag meron kang 100,000 colonies on your urine culture but you do not have any symptoms, that would be termed as your asymptomatic bacteria. If you have 100 colonies and then you have lower urinary tract symptoms but no systemic illness, that's your acute cystitis. But once you get fever, chills, malaise, your systemic symptoms, that would already point to the presence of acute pyelonephritis. For ASB and your acute cystitis, you may treat these on an outpatient basis, but for acute pyelonephritis, these patients should be admitted for IV administration of antibiotics as well as for hydration. So, asymptomatic bacteriuria, for untreated cases of asymptomatic bacteriuria, it has been found that those untreated would progress to cystitis or pyelonephritis in 25 to 40%, which is why even if without any symptoms, we treat patients with ASB. So, syempre, di ba, patients na may ASB, na hindi naman buntis, hindi naman natin yan usually tina-treat. But for pregnant women na may ASB, we immediately treat them because we do not want them to progress to cystitis or pyelonephritis. Because pyelonephritis especially has been associated with preterm births and other pregnancy complications. So, if you're not using the urine culture for the diagnosis of ASB, you may use your urinalysis, pero syempre ideal pa rin yung urine culture. In your urinalysis, you would find leukocyte esterase, nitrates, or hematuria present. And urine sediments would usually also have elevated WBCs and bacteria. So in the first trimester, penicillins and cephalosporins are the first line antibiotics we would use. And the usual treatment duration should be at least 7-day antibiotic course. Meron tayong mga single dose therapy nowadays, so that's your fosfomycin, but in Williams, mas okay yung 7-day na antibiotic course. Also important to know that your E. coli would cause majority, as in 80% of your asymptomatic bacteria and your UTIs. So for cystitis naman, instead of a 7-day regimen, we do a 7 to 10-day antibiotic course, and this is adjusted depending on culture sensitivity. For both your ASB and your cystitis, we obtain a test of cure 2 weeks after completion of therapy. And if the test is still positive, meron ka pa ring ASB or cystitis, then you should initiate a different regimen for 14 days. And for patients na diagnosed na with ASB prior, you should test for urine culture or urine CS every other trimester because there's high risk for recurrence. Okay, so ang pinakaayaw talaga natin na complication, that's why we treat early, is pyelonephritis. Besides ASB and the presence of cystitis, pregnant women are at a higher risk for complicated UTI because of increased urinary stasis from mechanical compression of ureters and progesterone-mediated smooth muscle relaxation. So remember, your progesterone would decrease bladder tone, and this would also cause increases in your ureteral and renal pelvis dilation and decreased ureteral peristalsis. So, at higher risk talaga yung pregnant women natin for pyelonephritis. And as we said earlier, E. coli is the most common species isolated. Pyelonephritis could be found in 1 to 2.5% of pregnancies. And for those na nagkaroon na ng pyelonephritis, around 10 to 18% of which would have recurrence during the same pregnancy. So, kaya ayaw natin ng pyelonephritis because 20% of those na merong acute pyelonephritis would progress to multi-system involvement and secondary to endotoxemia and would cause sepsis. So, it's very dangerous for your gravid woman. So, for the management of pyelonephritis, we initiate IV hydration, especially for common transient renal dysfunctions. And again, we should give IV antibiotics in the form of cephalosporins or ampicillin and gentamicin until your patient is afebrile for at least 24 to 48 hours, after which you can shift her to oral antibiotic regimen to run for 10 to 14 days. So next, infectious process in pregnancy, we have chorioamnionitis, and it's described as the infection of the membranes and amniotic fluid. Your chorioamnionitis has been associated in preterm, especially those with prolonged rupture of membranes. So ano nga ulit yung cutoff natin for prolonged rupture of membranes? That's 18 hours. Chorioamnionitis complicates 0.5 to 10% of pregnancies, and it can be diagnosed histologically in up to 20% of term deliveries and more than 50% of preterm deliveries. So, mas common talaga siya sa preterm patients. Now, chorioamnionitis may be termed as triple I, which means intrauterine inflammation, infection, or both. And your III, your chorioamnionitis, is actually the most common precursor for neonatal sepsis. So how do we diagnose chorioamnionitis? We diagnose this with a combination of fever as high as 39 degrees Celsius based on oral maternal temperature, plus another clinical criteria, which is either elevated maternal WBC count of more than 15,000, purulent fluid from the cervical os, fetal tachycardia, or evidence from amniocentesis consistent with microbial invasion. And our minimum criteria, the most important criteria ay yung nakaread dyan, fever, 39 degrees Celsius. That's our minimum criteria for the diagnosis of chorioamnionitis. If hindi tayo umabot ng 39 degrees Celsius, like for patients with a temperature of 38 degrees or more, but less than 39, kapag isang beses lang, it's not applicable in the diagnosis of III, but two measurements na 38 degrees or more, 30 minutes apart with a clinical factor, as mentioned here, could be used for the diagnosis of your III. But the gold standard of which, although syempre mahirap, would be culture of your amniotic fluid obtained via amniocentesis. Chorioamnionitis necessitates delivery, excluding other causes. So if magsa-cesarean delivery ka for chorioamnionitis, you use either metronidazole or clindamycin, or broad-spectrum antibiotics which would cover anaerobes. And after the delivery, you should continue antibiotics after the CS for at least 12 to 24 hours. Okay, so our next infection in pregnancy is your herpes simplex virus. So your herpes simplex virus infection would stem from either two different HSV viruses that are distinguished based on immunological differences. However, both HSV types have significant DNA homology, and prior infection with one type would attenuate a primary infection with another. Yung type 2 HSV natin, it's almost exclusively from the genital tract and it's transmitted sexually. Pero yung type 1 is responsible for most non-genital infections and is typically acquired in childhood. However, dumadami na yung cases natin of HSV1 infection, especially in the adolescents and young adults. So, ang classical presentation natin for herpes simplex would be papular eruption with itching and tingling, and then this would become a painful and vesicular lesion. For HSV, madalas meron tayong peripartum transmission, and the most common route is vertical transmission. Mas madalas yung vertical than after delivery na transmission to the neonate. So, neonatal infection of HSV, it could be disseminated, it could involve just the CNS or localized. So, ang disseminated infections natin would comprise 25% and would present with coagulopathies, pulmonary failure, liver dysfunction, high mortality rates, and morbidities. Some patients would just present with central neurologic symptoms and would present with seizures, lethargy, irritability, tremors, temperature dysregulation, and bulging fontanelles. So around 30% would present with just CNS symptoms. And the rest would be just localized to the skin or the eye or the mouth. So this is an example of your localized herpes simplex virus infection in the neonate. So, ano bang mga pinaka-important na points sa HSV? So, HSV screening is actually not recommended. And for mothers na nagkaroon ng HSV, you could give acyclovir. It appears to be safe for use during pregnancy. For women, though, na merong active lesions or prodromal symptoms on the time of delivery, the delivery should be through cesarean section, and you cannot do vaginal delivery. Women with HSV may breastfeed as long as there are no active HSV lesions, and strict hand washing should be advised. Again, yung acyclovir natin, it's still used during breastfeeding. If not acyclovir, you may also use valacyclovir for women na nagpapa-breastfeed. And HSV infection since it's usually sexually transmitted, symptomatic partners should also be treated for HSV, and asymptomatic partners should be questioned concerning histories of previous genital lesions and be offered type-specific serologic testing. Varicella zoster virus, or your VZV, is a dsDNA herpes virus, the primary infection of which is your varicella or your chickenpox, and the reactivation of which of your latent infection is called your herpes zoster or your shingles. Ang primary transmission natin would be through respiratory droplets or direct contact, but it may be transmitted perinatally, postnatally, as well as in utero. Ang incubation period is usually 10 to 21 days, and a non-immune woman has a 70 to 90% risk of becoming infected after exposure. Your primary varicella has a 1 to 2 days prodromal time, prodromal symptoms, so ito yung mga malaise, fever, headache, which is followed by pruritic vesicular lesions that would crust after 3 to 7 days. So ito yung beginning ng crusting natin. Affected patients are contagious starting 1 to 2 days before the rash onset. 1 to 2 days before the rash onset until all lesions have crusted. Okay? For congenital varicella syndrome, for these patients, for these babies, ang clinical presentation nila would mostly have chorioretinitis, microphthalmia, cerebral cortical atrophy, growth restriction, hydronephrosis, limb hypoplasia, and cicatricial skin lesions. And the highest risk of infection for your congenital varicella syndrome is between 13 to 20 weeks AOG. So ito yung highest risk for vertical transmission, during which around 2% lang naman of exposed fetuses had evidence of the infection. Beyond 20 weeks, the research have found that there's no clinical evidence for congenital varicella. But if near delivery nagkaroon ng varicella yung mother, dun siya pwedeng magkaroon ng primary infection ng varicella. Okay, so that's your neonatal varicella. And your neonatal varicella is due to maternal infection in the 3rd trimester, specifically 5 days before delivery and up to 48 hours postpartum. For patients, for neonates na merong neonatal varicella or may high possibility for neonatal varicella, they are given varicella zoster immunoglobulin during delivery. And the diagnosis of which, the infection is confirmed via PCR testing of your vesicular fluid or crust that is lifted from the skin. Your congenital varicella may be diagnosed via PCR testing of your amniotic fluid, and although a positive result does not correlate well with developmental of the congenital infection. So, pwedeng positive, pero it does not automatically mean that you will have the syndrome. An ultrasound may be performed at least 5 weeks after maternal infection to disclose abnormalities, but the sensitivity of your ultrasound is actually low, so it's not usually done. For VZV-affected fetuses, greater antenatal surveillance is typically implemented through serial sonography to identify poor growth. So for post-exposure prophylaxis and treatment, so exposed gravidas with a negative clinical history for prior chickenpox or vaccination should undergo VZV serological testing. At least 70% of these women would be seropositive and thus immune. So okay lang, di natin kailangan bigyan ng kahit na ano. Seronegative women should be given intramuscular varicella IG 125 IU per 10 kilograms of body weight up to a maximum dose of 625 units, or that's 5 vials. Although it is best given within 96 hours of exposure, it may be extended up to 10 days to prevent or attenuate varicella infection. And in women who have been found to have a history of chickenpox or varicella vaccination, varicella IG is not indicated. Parvovirus B19 is a single-stranded DNA virus that replicates rapidly in your proliferating cells such as your erythroblast precursors, and this can lead to anemia, which is its primary fetal effect. So it's also called your fifth disease, or your erythema infectiosum. In individuals with increased red cell turnover, such as in those with sickle cell disease, parvovirus infection may even cause a plastic crisis. The primary mode of transmission of your parvovirus is respiratory secretions, and maternal infection rate is highest in women with school-aged children and in daycare workers. So yung viremia of parvovirus B19 that usually develops 4 to 14 days after exposure, and the rash would follow days after. So nauuna yung infectious period before the rash. So an otherwise immunocompetent individual is no longer infectious once nagkaroon siya ng rash. And by adulthood, only 40% of women are susceptible. The annual seroconversion rate is 1 to 2%, and the secondary attack rate approaches 50% in patients with parvovirus B19, although hindi na masyadong important. In 20 to 30% of adults, the clinical presentation may be asymptomatic. In others, there would be a flu-like prodrome beginning in the last few days of the viremia period. And then several days later, they would have a bright red rash with erythroderma affecting the face. So ito yung tinatawag natin na slap cheek appearance. And this rash eventually becomes lace-like and would spread to the trunk and extremities. The vertical transmission of your parvovirus is around 35%, up to a third of maternal parvovirus infections. And they have been associated with abortion, non-immune hydrops, and stillbirth. So kapag first trimester naging infected, a lot of them would go into miscarriage. But if mid-trimester or in later gestations naging affected, they may cause fetal hydrops. So the critical period of fetal hydrops is 13 to 16 weeks AOG based on Williams 26th edition. So this is a summary table of the algorithm ng evaluation and management of your parvovirus B19 infection. Very important lang malaman dito na 1, you diagnose the infection through your IgG and IgM, and most cases of your parvovirus-associated hydrops develop the first 10 weeks. So, kapag meron kang recent na parvovirus B19 infection, it's recommended that you do a targeted ultrasound with MCA velocimetry. Yung middle cerebral artery kasi natin would be the artery in your Doppler velocimetry that would point to fetal anemia. So, important yung MCA Doppler interrogation natin to predict fetal anemia. And you do it every 2 weeks for 10 weeks after the exposure or infection. And if you have a sonographic evidence of your fetal infection, you should do chordocentesis, so test for fetal blood. You check for the CBC, reticulocyte count, check kung affected talaga siya ng parvovirus through your PCR. And if affected, you should do intrauterine transfusion. Okay. Cytomegalovirus, it's the most common cause of congenital viral infection. And yung symptomatic natin na CMV is a syndrome affecting 5 to 10% of fetuses, showing the following: growth restriction, microcephaly, chorioretinitis, mental and motor retardation, sensory neural defects, hepatomegaly and jaundice, and your hemolytic anemia. For rubella, it's caused by an RNA togavirus, also called as your German measles, the transmission of which would be through nasopharyngeal secretions, and the incubation period natin is 12 to 23 days. Patients with rubella would present with mild febrile illness, but they may also present with generalized maculopapular rash from the face and then extending to the trunk and extremities. Other presentations would include arthralgias, neck lymphadenopathy, conjunctivitis. However, 25 to 50% of which are asymptomatic. The diagnosis ng rubella is through your rubella IgM antibody. So for those women na nagkaroon ng rubella during the pregnancy, they may predispose the baby to CRS or your congenital rubella syndrome. Rubella infection effects are worse if the infection was during organogenesis. In fact, up to 90% based on Williams um, are would be if infected if the mother was infected at before 12 weeks age of gestation. In blueprints, that's 50 to 80%. Basta ang point is, before 12 weeks, sobrang high ng incidence mo for CRS if before 12 weeks nagkaroon ng infection yung mother. And it decreases as the gestation goes. So, features of your congenital rubella syndromes would include your cardial septal defects, pulmonary stenosis, microcephaly, cataracts, microphthalmia, hepatosplenomegaly. Other abnormalities would also include sensory neural deafness, intellectual disability, neonatal purpura, and radiolucent bone disease. Pati yung blueberry muffin actually can also be seen in congenital rubella syndrome. And ito yung sinasabi natin na BBBB or bingi bulag bobo. Butas ang puso, blueberry muffin rash. So, your neonates nyo actually na merong congenital rubella may shed the virus for many months and thus may be a threat to other infants and to susceptible adults who would have contact with these babies. For the management of rubella, there's actually no treatment. You should do droplet precaution lang for 7 days after the rash onset. And there's a rubella IVIG, and it may be of benefit if given within 5 days of exposure, although this is not usually done. And again, MMR vaccine, kaya natin sina-check din ang rubella IgG sa pregnant women. If they're seronegative for rubella IgG, MMR vaccine should be offered postpartum. And for those desirous of pregnancies na seronegative for rubella IgG, they should be given your MMR vaccine at least a month prior to conception. For HIV women naman, we may actually do vaginal delivery. It's very important to know that we can do vaginal delivery for HIV women, especially if they are on antiretroviral therapy, and as long as the viral load is less than 1,000 copies per ml. But if your patient does not meet this criteria, you should do cesarean delivery at 38 weeks. For patients na may HIV, Zidovudin is recommended 3 hours prior to delivery as it was found to decrease transmission by 80%. And during labor, whether vaginal or cesarean delivery, there should be minimal contact between the infant's skin and mucous membranes of the mother, maternal blood, and genital secretions. After delivery, babies who are born to HIV-infected mothers should be bathed immediately and should be started with zidovudin therapy within 12 hours of delivery until 4 to 6 weeks postpartum. If hindi nabigyan yung mother na antepartum prophylaxis, they should be given 2-drug or 3-drug regimen. So that's zidovudin plus nevirapine or zidovudin plus nalfinavir and lamivudin. Very also important to note that breastfeeding is contraindicated in HIV-infected women because their postnatal HIV transmission from breast milk at 2 years is as high as 25%. For syphilis, syphilis has been associated with stillbirth, neonatal death, and a pale large placenta. However, in some patients, they may be asymptomatic up to 2/3 of patients at birth. But for babies na with syphilis, they may develop the symptoms until 3 to 8 weeks postpartum. So for congenital syphilis, there is a difference between the presentation if you develop it early or late in the pregnancy. So for those na early na infect with syphilis, you can get non-immune eye drops, IUGR, reticular endothelial abnormalities, mucocutaneous lesions, bone abnormalities, ocular abnormalities, as well as CNS abnormalities. Those with late congenital syphilis, ito yung mas common ang neurological abnormalities, mental retardation, deafness, dental abnormalities. Sila yung mga may Hutchinson's teeth and peg-shaped upper incisors, and mulberry molars. These babies would also present with frontal bossing, short and protruding mandibles, saddle nose, flaring scapula. So ito yung mga may late congenital syphilis, as shown in this photo. Hepatitis B naman, we do a universal screening of all pregnant women with your HBsAg. If positive, we check for the hepatitis profile and HPV DNA. Kapag ang HPV DNA mo is more than or equal to 200,000 IU per ml, that's when you start antiviral therapy. And the first line of treatment would be your tenofovir for hepatitis B. For those na susceptible during pregnancy, vaccine may be given, but it's not routinely done for patients na hindi naman susceptible. And immunoprophylaxis for hepatitis B is given through the form of a hepatitis B immunoglobulin and vaccine for infants born to infected mothers within 12 hours of birth. Okay? So let's move on with seizure disorders in pregnancy. Isa dito sa mga favorite topics nila. So in general, patients with uncontrolled epilepsy prior to conception would be noted to have increased number of seizures during pregnancy. And this is due to various reasons per individual. So first, there may be decrease in the levels of your circulating anti-epileptic drugs due to several maternal physiologic processes. So your increased volume of distribution, remember, in pregnancy, there's an increased plasma volume of 40 to 50%, diba? To compensate for increased metabolic demands and to protect your fetus for impaired venous return. So yung pregnancy hypervolemia nyo, offset with protein binding, decreases the levels of circulating AEDs in the body. So another reason would be due to the increased estrogen. Estrogen has been found to be pro-convulsant as it increases the function of your CYP450 enzyme sa liver, diba? Which promotes hepatic metabolism of your anti-epileptic drugs. So levels are also decreased in patients with vomiting. So not only due to decrease in the drug intake as a result of expulsion, but also due to diminished absorption with the use of antacids, such as in patients with hyperemesis gravidarum and increased GERD. And lastly, clearance is faster due to increased glomerular filtration rate during pregnancy. Besides the physiological processes that may affect AED levels, there is also a decreased seizure threshold in pregnancy due to sleep deprivation, increased stress, and even pain and hyperventilation during labor. And last, in some patients, there is decreased compliance with AEDs, mostly out of fear of acquiring fetal congenital malformations with the use of AEDs during pregnancy. So besides the risk for neural tube defects and increased seizure episodes, there is also higher risk for fetal comorbidities, including miscarriage, growth restrictions, and preterm births. And for maternal comorbidities, this would also include obstetric hemorrhage, hypertensive disorders, placenta abruptio, and cesarean delivery. Postpartum depression is also common in women with seizure disorders. And for the children of women with seizure disorders, there's a 10% risk of developing seizure disorders in their lifetime. Also important to note that there have been reports of increased risk of spontaneous hemorrhage in newborns because of the inhibition of your vitamin K-dependent clotting factors 2, 7, 9, and 10, secondary to increased vitamin K metabolism and inhibition of your placental transport of vitamin K by your anti-epileptic drugs. So although the risk is small, conservative management is done by overcoming this theoretical vitamin K deficiency through supplementation of vitamin K towards the end of pregnancy. So, several studies have concluded that the best predictor of seizure frequency in pregnancy is the amount of seizures in the year prior to pregnancy. And each patient with epilepsy disorder should be counseled prior to conception of the possible risk of pregnancy, and the best way is to prevent them. Our goal before pregnancy is monotherapy with the least teratogenic medication and the lowest possible dose. Epileptic women have an increased risk of fetal malformations even without AED, but more so with AED use. Thus, folic acid supplementation at a dose of 0.4 milligrams per one tablet at least once a month before conception should be advised. And this value is increased to 4 milligrams per day once pregnant. Um, for patients na seizure-free for 2 years or more, we can attempt to complete withdrawal from your anti-epileptic drugs prior to conception. But that's if they're seizure-free for 2 years or more. So this table is from ACOG that summarizes the obstetric and gynecologic risk of your anti-epileptic drugs. So as you can see, valproic acid has been shown to have the greatest risk for congenital malformations, going as high as 10% in its users. So for valproic acid, there is a higher risk of teratogenic effects when used alone compared to when it is used in polytherapy actually. And yung valproic acid nyo, it has been found to be associated with your neural tube defects, cardiac anomalies, and hypospadias. The least teratogenic of the AEDs is your levetiracetam with only a 0 to 2.4 increase risk for malformations. So, kung makita nyo dito, yung most frequent natin na major malformations, they're actually your cardiac anomalies and cleft lips, besides your neural tube defects. So, no evidence suggests that regular monitoring of your anti-epileptic drugs levels would improve seizure control. So, therefore, routine monitoring of serum AED levels in pregnancies is not recommended. But for patients na merong increased seizure activity, meron kang non-compliance, meron kang suspected toxicity, you need to adjust some doses ng phenytoin or lamotrigine, or you need, if there are changes with drug interactions, or if there are signs of organ failure or unwanted side effects, you may do monitoring. So epilepsy is not an indication for induction of labor or cesarean section. Women may still undergo trial of labor. And epilepsy is also not a contraindication to the administration of your neuraxial analgesia or anesthesia. So yes, pwede ka pa rin mag-epidural, pwede ka pa rin mag-spinal. Postnatally, they should be monitored 24 hours after delivery, and they should be observed closely for the next 72 hours. Continuation of an anti-epileptic drug dose for the first 24 hours post-delivery is then reduced gradually to pre-pregnancy dose over the next 3 to 4 weeks to avoid toxicity. And for women desiring to breastfeed, data regarding the safety of the various anticonvulsant medications are limited. However, no obvious deleterious effects such as long-term cognitive issues have been reported, and thus breastfeeding is still recommended, especially since the concentration of AEDs in breast milk is minimal. But important to know that some newborns may become irritable and fall asleep shortly after beginning to nurse or fail to thrive with the use of highly sedating drugs, especially immediately before delivery. And these would include your phenobarbital, primidone, and benzodiazepines. Okay, so last, you have your systemic lupus erythematosus. So like your bronchial asthma in pregnancy, your SLE has a 1/3 rule. So 1/3 would improve, 1/3 would worsen, and 1/3 would remain unchanged. So compared to your lupus flares compared to your preeclampsia, both of which are actually mediated by antigen antibody complexes, which would produce vasculitis. In your lupus flare, malalaman mo na lupus flare siya because there's reduced C3 and reduced C4, and you would see that there are active urine sediments in your urinalysis. As compared to preeclamptic na vasculitis, you would find that C3 and C4 are normal and there would be no urine sediments. So the treatment of your flares would, if by preeclampsia is through delivery, and if it's a lupus flare, you give high-dose corticosteroids and cyclophosphamide. It's also possible to have neonatal lupus in the babies of your patients with SLE. And there are two distinct complications. So it's, specifically, your lupus syndrome and your congenital heart block. So pag lupus syndrome, we would present with skin lesions, hepatosplenomegaly, and low blood counts. And yung congenital heart block natin, so it damages specifically the AV node. And yung serum marker natin for a possible congenital heart block is your anti-Rho or SSA and anti-LA or your SSB. So treatment then ng neonatal lupus would involve your corticosteroids, plasmapheresis, and IVIG. Okay. And that's the end of your second lecture in OBGYN. We'll try to discuss more important topics in your Pearls lecture. But for now, congratulations. At lagi namin sinasabi sa OB, I know it's overwhelming. PLE season is overwhelming, but hingang malalim, pigil hininga, and push.